All right, let's talk about cryoglobulinemia. Now, this is one of those conditions that's a real master of disguise, popping up where rheumatology, hematology, and infectious disease all meet. Honestly, getting a handle on this is so important, not just for your specialty exams, but for your day-to-day clinical practice. So, let's dive in.
And just a quick note, for our roadmap through this pretty complex topic, we're building this explainer on the fantastic work of Dr. Muhammad Al-Naghi Muhammad. His material really provided the perfect foundation for everything we're about to cover.
Okay, let's kick things off with a classic clinical scenario. Imagine a patient comes in with achy joints. On exam, you notice this purpuric rash on their legs, but it's not just flat spots. You can actually feel it. It's palpable. That's a huge clue for inflamed blood vessels. Then the labs come back and boom, their C4 complement level is in the basement. So with this classic triad, purpura, arthralgia, low C4, what diagnosis should be jumping to the top of your list?
Well, if you were thinking cryoglobulinemia, you're exactly right. That triad is practically screaming the diagnosis. But to really get why those three things go together, we have to go back to basics and figure out what exactly is a cryoglobulin.
So, at its very core, the concept is pretty wild but simple. Cryoglobulins are just immunoglobulins, antibodies, that have this really weird property. They get sludgy and clump together when they get cold, like around 4 degrees Celsius, and then they completely dissolve again when they warm back up to body temperature. Just picture that happening inside the tiny blood vessels in your patient's fingers, toes, and skin. That clumping and unclumping is what drives this whole disease. And, while we usually find an underlying cause, it's worth remembering that for about a third of these cases, we never do. They're just idiopathic.
But here's the thing. It's not enough to just say, yep, the patient has cryoglobulins. You've got to know what kind they have. The classification system here is absolutely critical because the type of cryoglobulin is a direct clue, like a giant flashing arrow, pointing you straight to the underlying disease. Honestly, if you're studying for an exam, this is probably the most high-yield part of our whole discussion today.
So, when we use what's called the Brouette classification, we split them into 3 main types. You can see here that type 1 and type 2 each make up about a quarter of all cases. But look at type 3. It's the most common by a long shot, accounting for a full half of all cases. Now, let's really get into the nitty-gritty of what makes each type different.
This table right here, this is the money slide. It brings it all together. Let's start with type 1. You see, it's made of a single monoclonal antibody. As soon as you hear monoclonal, your brain should immediately jump to hematologic malignancies, things like multiple myeloma or Waldenstrom's. Now look at types 2 and 3. They're both called mixed types, and they both have rheumatoid factor activity, which just means the antibodies are attacking other antibodies. The key difference, type 2 has a monoclonal piece in that mix, while type 3 is purely polyclonal, meaning it's made of lots of different antibodies. And those clinical associations are just vital to know. Type 2 is famously linked with hepatitis C. Both 2 and 3 are also tied really strongly to autoimmune diseases, especially rheumatoid arthritis and Sjogren's syndrome. So we've covered the what, and we've kind of covered the why. Now let's talk about the how. How does this actually show up in a patient who walks into your clinic? What are the key signs and symptoms that we need to be on the lookout for?
All the clinical features are really driven by one central process, small vessel vasculitis. It's those precipitated immune complexes causing inflammation and damage. The most common thing you'll see is that palpable purpura we talked about, especially on the legs. But the damage can get much more serious, causing things like painful skin ulcers, that nagging joint pain, and even life-threatening inflammation of the kidneys, called glomerulonephritis.
Okay, now here's a super important clinical pearl, especially if you're taking an exam. Pay attention to this one. While vasculitis can happen in all 3 types, Raynaud's phenomenon, that classic white, then blue, then red color change in the fingers when they get cold, that is almost exclusively a feature of type 1. So, if you see a patient with cryo symptoms and Raynaud's, you should be thinking very hard about a monoclonal process like a myeloma.
All right, so you've got your clinical suspicion. It's high. Now you've got to prove it with some lab work. And thankfully, there are 2 really characteristic findings that can help us nail this diagnosis down.
The single most important lab finding, and I can't stress this enough, is a low complement level, specifically a profoundly low C4. So why is that? Well, those antibody clumps, those cryoglobulins, are incredibly good at firing up the classical complement pathway. Think of it like a row of dominoes.
C4 is one of the very first dominoes to get knocked over in that inflammatory cascade, so its levels just get totally consumed and drop. A low C4 is a true hallmark of this disease.
Another really common lab finding is a high erythrocyte sedimentation rate, or ESR. Now, on its own, a high ESR doesn't tell you much, right? It's just a nonspecific marker of inflammation. But when you see a high ESR alongside the classic clinical picture and that telltale low C4, it adds a ton of weight to the diagnosis of cryoglobulinemic vasculitis.
Okay, so we've confirmed the diagnosis. What's next? We have to treat it. And the approach here is really logical. It follows a pretty clear three-pronged strategy.
First, and this is without a doubt the most important step, you have to treat the underlying cause. If it's hepatitis C, you treat the virus. If it's a lymphoma, you treat the cancer. That's the only way you're going to shut off the factory that's producing these cryoglobulins in the first place. Now, while you're getting that under control, you can use immunosuppressive drugs to calm down the vasculitis. And in really severe, life-threatening cases, you can use plasmapheresis as a sort of bridge therapy to physically wash these harmful antibodies right out of the blood.
And that really brings us to our final and maybe most critical takeaway point today. Finding cryoglobulins in a patient's blood is not the end of the diagnostic journey. It's the beginning. It's a huge clue. Think of it as a big, flashing neon sign that's pointing to some other hidden disease. So when you find them, your work isn't done. It's really just getting started. The most important question you can possibly ask is always going to be, what is the cause?